Assalamualaikum warahmatullahi wabarakatuh and good day everyone. My name is Hafiz Amirul and I'm the head of project for building resilient communities at Mercy Malaysia. We're making this video to share with you a bit of an introduction to one of our program which is known as Resilient Health Infrastructure. Resilient Health Infrastructure is part of our Building Resilient Communities, or BRC in short, initiative that was planned and designed with the objective of reducing the humanitarian burden and also to build resilience of people and places for them to be more prepared and able to cope themselves in times of disaster and crisis. A bit of an introduction on how does this BRC agenda started off. It started when the Sendai Framework for Disaster Risk Reduction was adopted, and we see, Mercy Malaysia sees the importance of reducing the divide between humanitarian and development. Therefore, BRC was designed to perform such a way. There is a need to transcend the divide between relief aid and development work so that we can deliver better results for the people. And having said that, our BRC main objective is, there's three main objectives to it, which is number one, to achieve economic prosperity and continuity, environmental stewardship, and also social well-being and continuity. These three main pillars are then translated into stakeholders in the form of local communities, children and youth, health facilities and service providers, the private sectors, and local government units. By embracing and working together with these 5 groups of community, it is hoped that the initiative can help to strengthen and build resilience among community. For today, our focus will be on RHI, or Resilient Health Infrastructure. From this diagram, you can see that various types of activities ranging from the drafting of policies and regulation, planning works, research and development, innovation transfer, the building of safe schools, capacity building, rebuilding of safe structure, and so on, are part and parcel of the whole BRC agenda. As part of the Resilient Health Infrastructure Program, Mercy Malaysia has been conducting its Resilient Hospital Workshop. And here are the 4 methods and structure of conducting that workshop. Number 1, we will start with the capacity building of the hospital staffs, which include doctors, nurses, medical officers, and other subject matter experts. Number 2, we conduct participatory activities in the form of experience sharing and discussion. And number 3, we conduct hazard, vulnerability, and capacity assessments. Finally, to conclude all 3, we summarize that through a disaster simulation exercise in order for the participants to discuss and work on their disaster action plan in increasing the hospital's resilient level. Now, what is a resilient hospital? It is important to understand the concept of disaster risk reduction before we continue with the whole understanding of making a hospital more resilient. First, we must acknowledge the fact that healthcare organizations must continue to operate during crisis. This is a matter of patient safety, public services, and business continuity. Making hospitals more resilient is a product of planned preparation in strengthening hospital capacity to respond effectively to disaster and fast recovery from extreme events. Considering hospital as a complex organization in terms of its physical built environment and human resources, Mercy Malaysia has identified 4 main criteria in making a hospital more resilient. The 4 main criteria of making a resilient hospital includes robustness, meaning the strength of the built environment and other physical infrastructure of the hospital. Number 2, redundancy in terms of resilience infrastructure and components. Number 3, resourcefulness of its human resources and safety procedures. And finally, number 4, rapidity in terms of its disaster action plan and operations. Hospital resilience can be achieved through the adaptation of the disaster risk reduction approach, or in short, DRR. DRR is a systematic approach to identifying, assessing, and reducing the risk of disaster. It aims to reduce socio-economic vulnerabilities to disaster as well as dealing with the environmental and other hazards that trigger them. If you look into this picture, this is a photograph of a collapsed building in Nias Island, Indonesia, which was hit by a strong 8.5 magnitude earthquake in 2005. It is clear that from this photograph, disaster or earthquake don't actually kill people. It is actually the unsafe structure that do so. Therefore, the understanding of DRR is a concept and practice of reducing the risk and impact of disasters through systematic efforts in analyzing and managing disaster factors, which include, but not limited to, number 1, reducing threats and harm of disaster in general. Number 2, reducing threats on people and properties. Number 3, policies in land and environmental planning. And number 4, increased disaster preparedness. It is clear that from these 4 factors, DRR includes both hard and soft approach in protecting people and saving life. When DRR started? It started in 2005 officially when the world convened in Kobe, Japan to discuss issues on disaster risk reduction, and that discussion produces a non-legally binding framework which is known as the Hugo Framework for Action, or in short HFA. This framework was the guiding principle from 2005 until 2015 for the world to work towards reducing disaster risk. It outlined 5 priorities of action, which include making disaster risk reduction a priority, improving risk information and early warning, building a culture of safety and resilience, reducing the risk in key sectors, and strengthening preparedness for response. In 2015, the world reconvened again in Sendai, Japan, to further discuss the agenda of DRR, which now include the bigger agenda of building resilience. The Sendai Framework for Disaster Risk Reduction, or SFDRR in short, is a 15 years non-legally binding agreement which outline 4 priorities of action. These include, number 1, the understanding of disaster risk, strengthening disaster risk governance to manage disaster risk, investing in disaster risk reduction for resilience, and enhancing disaster preparedness for effective response and to build back better in recovery, rehabilitation, and reconstruction. Why do we need DRR? From research, it is known that no government in the world that can guarantee the safety of its citizens when disaster happened. Therefore, society needs to have the ability and must be prepared in reducing its socio-economic vulnerability during the event of disaster. This is very related to the fact that the community may have all the experience, method, knowledge, tools, resources, and most importantly, time for them to respond to disaster and also manage disaster risk. In understanding disaster risk, we can calculate conceptually the level of a disaster risk of a particular community. By knowing the level of hazard and vulnerability of an area, which then can be divided by the level of resiliency or coping capacities of that particular community, disaster risk can be calculated. The next question is, why the need for a resilient hospital? It has been researched that a hospital needs to be resilient because it is susceptible to disaster risk. Hospital failure will increase number of patients and will multiply numbers of disaster victims. And in the event of disaster, there is an increasing need for emergency care. Loss or shortage of hospital workforces during disaster will eventually reduce its capacity in responding to disaster. And of similar importance, critical systems for any hospital, such as its electricity, water supply, sanitation, waste management, and medical disposal, could jeopardize the ability of the affected hospital. The objectives of conducting a resilient hospital workshop are for hospitals not to be badly affected during and after a disaster, and to make sure hospitals are able to function during and after a disaster. In understanding the concept of resilient hospital, it is important for us to understand the whole DRR idea at first. The sharing of experiences from hospitals that had experienced disaster would also be very helpful for us to understand this concept. It is then followed by activities on disaster risk mapping and conducting hospital watching exercise, which then allows participants to develop and implement its own resilient hospital strategic action plan. By looking at this image, it is clear that vulnerability factors can be identified and measured. In working together towards a resilient hospital, it is important for us to identify factors of vulnerability in the hospital. As an example, in this photograph, elements that can cause vulnerability for the hospital can and must be identified, recorded, and acted upon in building its capacity. In this image, a flood mitigation wall was constructed, and that has helped to keep the hospital in operation during times of flooding. So the next step in continuing with the Resilient Health Infrastructure program is after the completion of the introduction to building a resilient community and disaster risk reduction, as well as the introduction to RHI, we follow through with an exercise which is known as hazard timeline and Venn diagram, where participants of the hospital staffs will be involved in identifying and also sharing what types of disaster that they have experienced and what are the action taken in responding to disaster. And after that session, we dedicate a session where selected hospital staff would present their specific experience sharing, which also include on how they cope and how they respond to previous disaster experience. Following that is the exciting hospital watching exercise, which is inspired by the Japanese way of known as makizukuri, where they do communal planning, township planning on a community basis. So this hospital watching will focus on the identification of hazard, vulnerability and capacity, and they will form groups. They will be broken up into groups, and each group will have a facilitator, and Mercy Malaysia will pre-assess the hospital area and assign critical zones for these participants to conduct their hospital watching. During the hospital watching exercise, participants and facilitator will focus on the identification of hazards and also vulnerability factors, with also capacity factors within the four main components of the hospital, which is number one, the built environment itself, number two, the buildings and structures of the hospital, and then critical infrastructure, which include electrical substations, gas infrastructure, water tanks, and so on. And number four, equipments, which include medical and non-medical equipments. So these four elements will be the main focus, which they will record, which they will identify, record, and also make suggestion on how to improve the condition or the resilience level of these elements. This will be then bring back to the classroom, where they would present their findings, and expert staff from Mercy Malaysia, which are the technical experts, which include medical planners, architects, engineers, will give feedbacks and also inputs on what are the findings. So that is the hospital watching exercise session. Upon the completion of the hospital watching exercise, participants would required to put all findings into a systematic presentation, which then is followed up by Mercy Malaysia's team to summarize them. The next session is the disaster simulation session, which is conducted as a tabletop exercise. This is to test and also summarize the basic understanding of these participants on the overall concept of resilient health infrastructure. We will start with giving them a disaster scenario where they are required, the participants are required to prepare a preparedness plan, a disaster preparedness plan, and followed by a real disaster scenario where the participants are then required to activate their disaster preparedness plan and also activate their disaster action plan. So during this tabletop session, we applies the role play method, and also the participants will have to react to what the scenario which has been designed by the team. Again, the participants will be divided into 4 groups, mainly number 1 on hospital management and governance, and also those who take care of media policies and also NGO management. That's group number 1. Group number 2 will focus on buildings and critical infrastructure. So usually the resident engineer of that particular hospital will belong to this group. Number 3, a group that focuses on continuous medical services, and usually the doctors will be involved in this group. And number 4, groups that will take care of logistic planning and also communication and information management. So these 4 groups actually made up the complete structure of the disaster response team of the hospital. So from our previous experience of conducting this RHI and also the Resilient Hospital Workshop, we have received many positive feedbacks, especially from the hospital staffs, where they acknowledge the importance of being prepared and the importance of being resilient. But more importantly, they start to understand the real meaning of resilience and how they can act upon it. So this is the experience shared is being replicated and also being practiced by more and more people, in which we hope will be able to advocate this whole agenda of building a resilient community. With that, I would like to say thank you for your time and for listening to us. And we hope that this video would help to at least give the basic understanding of what building a resilient community is and what resilient health infrastructure is. Thank you very much.